Good morning, my name is Sorka McPhillips and I'm the Chief Executive of the Huntington's Disease Association Northern Ireland. I'm joined this morning by our trustees, Janice McCartney, who's a family member, Dr. Seamus Kearney, who's a consultant neurologist, and Dr. Lauren Byrne, who's a research scientist and family member based at the University College London. If our MLAs present would like to introduce themselves or the representatives, just to say who's with us today. Paula, you were first up, so I'll let you introduce yourself.
That's okay. Good morning, everybody. Paula Bradshaw, Alliance Party Health spokesperson, and I represent South.
And Colm Gildernew, Sinn Féin MLA for Fermanagh South Tyrone, Party spokesperson for Health.
Great.
Donna Meek, representing Pam Cameron, MLA DUP, and Pam is the Deputy Chair of the Health Committee.
Great. And we also have Sinead Bradley, but she might be having some difficulties with her communication there. So I'm going to start with a presentation, and it'll include a couple of videos of our service users to give you some insights into the issues affecting people in Northern Ireland with Huntington's disease. So if you bear with me, hopefully technology will serve us well this morning. Now, so Huntington's disease is a rare neurological condition. It causes a decline in cognitive function, behavioural problems, and physical impairments. It's a genetic condition that's inherited from a parent, and there's currently no cure. Men and women are equally affected, and the disease tends to start showing signs between the ages of 35 and 60, though a percentage of people will develop what's called juvenile Huntington's disease and show symptoms from childhood, and some people will not develop symptoms until later life. Once motor symptoms usually have become evident, disease will progress over the course of say 15 to 20 years until the person passes away. It's estimated very conservatively that about 12,000 people in the UK live with Huntington's disease. There's a 50% chance of passing the gene on to every single child that you have. It doesn't reduce with sex, and it doesn't reduce with the number of children who already have it. And there are a number of stages to the condition. Pre-manifest is where there's no symptoms yet. Early, mid, late, and end stages. So what causes Huntington's disease? Huntington's disease is quite unique for rare disease because they know exactly what causes the condition. On chromosome 4, there's a gene which causes a triplet expansion of different proteins. And this basically causes a stickiness and a mess in the brain that leads neurons to be killed away. It's possible to test for Huntington's disease when you're over the age of 18. And this is provided with a range of genetic counselling services through the Regional Genetic Service in Northern Ireland. And the results will show up as the number of these CAG repeats that you have. And this will determine whether or not you will develop the disease. So if you have 10 to 35 repeats, you're normal and you won't develop the disease. If you have more than 39 repeats, you will develop the disease at some point in your life. And then there's what they call a grey area of between 36 and 39, which may develop the disease, but it will just be a case of waiting and seeing what happens. So what kind of symptoms does Huntington's disease cause? There's physical symptoms like involuntary jerky movements called chorea, difficulty with walking, problems with speech, eating and swallowing becomes difficult. Early on, there could be the issues around behaviour and mood. So mood swings, depression, apathy, compulsive thinking, and anxiety would be quite common among people with Huntington's disease. And you could be experiencing some of these issues for years before you ever develop any of the physical symptoms. There's also a cognitive impairment, so slower thinking, it's harder to plan ahead, difficulty in doing more than one thing at a time, and becoming forgetful. Huntington's disease is one of the causes of dementia. But essentially, we find that no two people are exactly the same. And even within the same family, people can have more physical symptoms or more emotional symptoms. But more often than not, people will have experience across the whole realm of symptoms. So how many people were we working with in Northern Ireland? This is a really difficult question to answer, and there are a number of reasons for this. The map you see in front of you marks out the people that the Huntington's Disease Association Northern Ireland are connected with. Those include people who are currently diagnosed with Huntington's disease or have had a predictive test to say that they will develop the condition at some stage, people who are known to be at risk of the condition, and young people under the age of 30, including children, who are from Huntington's disease families. In Northern Ireland, the estimated population in July 2020 was 1.9 million. And if you extrapolate that based on the prevalence rate of 12 per 100,000 people, it's estimated that around 229 people in Northern Ireland will currently have Huntington's disease. And for every one person affected, very conservatively, it's likely that up to 5 more people are at risk. In Northern Ireland, then, you'd be looking at a population of over 1,100 people. HDANI is currently engaged with 100 HD positive or symptomatic people and 256 people that we know to be at risk. But it's not possible to provide accurate figures as there's no HD registry, and the Health and Social Care Trusts do not record the number of people they treat with HD. Instead, they keep records of people who attend neurology services or mental health services, but they don't recognise the fact that they're there for HD. So this makes it extremely difficult. And the map that we have in front of you only allows us to capture the people for whom we have postcodes. So we would have engagement with potentially carers or people who have had a diagnosis, and they don't want to fully engage with the charity, but they maybe come in for some information or some advice, and they speak on the phone, but they don't want to give out their contact information. So we can't capture that information. But at the minute, we're dealing with at least 100 people with Huntington's disease in Northern Ireland.
I was working in a new job, training as an ultrasound sonographer, and the girl who was training me noticed that I wasn't holding the scanner appropriately. From that point on, when I knew that I might be symptomatic, I knew I had to go and get tested. The day I went to get my test results, I was listening to Always Look on the Bright Side of Life. There's no tears actually when we went to get the test results, because we just both, my husband and I, because we'd already realised that it was going to be positive. There's no point in worrying about it, so just get on with it. I would struggle with multitasking. My concentration levels aren't very good either. Yeah, I struggle a bit trying to find the right words, even simple words in the middle of a conversation. I'll just suddenly stop because I'm trying to find the right word. I try and do some brain games to try and improve it sometimes, but hard all the time to keep it going. Yes, you're constantly tired. It makes you less coordinated. I find it a bit more clumsy, having a few more falls. It might happen that I need a wheelchair. A lot of people in the support groups do use relators or wheelchairs, so it might happen, but I'm going to stay positive and hope that it won't come to that. You're constantly thinking about death. That's the reality if you want to think about it 24 hours a day, and that's a very heavy negative thing. But I just try and take all the help I can get from going to counsellors and doing mindfulness things. The Huntington's charity in Northern Ireland, they provide a place to talk every month. Everyone gets to just have a chat, talk to people about normal stuff, or about if you've been having a bad week, you can blow off steam, or you can have a bit of fun. It's just having that support there, and they can help you. They can give you some skills as well at the meetings. It's not just chatting, and I know the support they do for all the families in Northern Ireland is just phenomenal. It gives hope to the HDANI community.
And it's one of the points that we want to really highlight today for MLAs is the health inequity that exists for HD families across Northern Ireland. So we're going to hear from some families in the Western Trust who will share their stories now.
My mother had Huntington's disease, and her brothers and sisters also had Huntington's disease, and I have cousins as well that have passed away with it. The impact has been dramatic. It's been overwhelming, from the sensation of knowing that you have on it, and knowing that there's no cure, and just all the uncertainties of it.
We were told whenever Mickey was diagnosed we'd have a cure in 10 years, and it's definitely not 10 years now. We're way past that. We're chatting nearly 20 years. So we've been thinking that there'll be something, and it seems to be all research has been done, and I think now you could start to get a bit scared that it's going to be run a bit too late for us. Joanna has a less than a 3% risk, and Annie has less than 1% risk. So they can get tested. They cannot. We could have got them tested obviously whenever they were in the womb, but we decided not to do that because of the risk. So we probably will ask Annie and John, be up to them right enough to make that decision to get tested whenever they turn 18, just to make sure that they'll not have it. So we're hoping that they'll both be clear now of Huntington's.
Ready? Where is she?
Here she
It's very scary to think they can have it, but I'm hoping if they do, well, obviously if they don't, but obviously if they do have it, hopefully there'll be a bit more help out there. Like at the moment, I'm really struggling with it because I find the movement and everything so uncomfortable, and I just feel like would like to go to someone that understands it, but there's no one there. You can't go to anyone. If it wasn't for me kids and the help, I would hate to think what road I would have gone down.
It's terrifying because everything I'm doing, you know, I might twitch at night, and is that Huntington's? It's always there on the back of your head. And then because I have my young daughter to worry, is she going to be affected by it in the future? So at the minute I haven't got tested, but I wouldn't rule it out for the future, because sometimes I think it would take away the what if, the not knowing.
We live in Gorchin, outside Omagh, and we fall under the Western Trust. There is no specialist nurse in the West for HD. There is an inequality. I don't understand any difference in me and somebody from Belfast, so why should there not be a HD nurse here as there is one in Belfast, really?
I think it's disgusting, to be honest. I just think it's wrong. I mean, why should we be penalised? Why should there be one nurse? I mean, there's so many people suffering with Huntington's. I mean, it's ridiculous that if you have a problem, you go to a doctor or you go to the health people, and they don't know nothing about Huntington's. Like, why don't they know enough about Huntington's? We should have more help out there.
Okay, so now I'm going to have a few words with Janice McCartney, who's one of our trustees and a Huntington's disease family member. I'm just going to stop this, and then I'm going to be handing over to Dr. Seamus Kearney, who's a consultant neurologist. And after that, you'll hear from Dr. Lauren Byrne, who's a research fellow at the UCL Huntington's Disease Centre and also a Huntington's family member from Northern Ireland. So Janice, I'm just going to unmute you. Can you hear me okay?
Yeah, I can.
Okay, great. So Janice, if you want to start by telling us how many people in your family actually have Huntington's disease or have already passed away from it?
There's 7 have and had altogether.
Okay. And if you think about all the children that those people have had, how many people are currently at risk in your family with Huntington's disease?
There's in around 45 and growing, obviously.
Yeah, that's the thing, growing. The population
Yeah.
is ever growing. Yeah, absolutely. So Janice, you cared for your dad, and your dad is where Huntington's disease came into your immediate family. Could you tell us a little bit about that?
The most difficult changes was watching my dad grow on from a normal, working, healthy person to slowly watching every part of his body die inside and out. HD affects your balance, your mental health, your walking, your talking, your swallowing, just everything.
What did your dad, George, do before he got sick? What did he work at?
He worked really hard. He worked at driving a digger and like doing road works and
so very
like
physical jobs.
And then I just going from that down to not being able to do anything.
And did he have to stop his work prematurely?
Yes, he did. He was only 58 whenever he passed away.
58. And how many brothers and sisters do you have, Janice?
I have one sister and one brother.
And we know that you also have cousins with Huntington's disease.
Yes, that's
and
right.
kids will be at risk as well.
Yeah.
So from a carer perspective, can you tell us how difficult it is to look after somebody with Huntington's disease?
Yeah, it's emotionally and physically looking after somebody with it. They depend so much on you. It's 24/7 in the later stages of it, because you have to watch that they depend on you so much, and you have to watch that they don't fall, that you have to feed them. You have to watch that they don't choke while you're feeding them. You have to take them to the toilet. You have to shower them, try to understand what they are looking and what they need, as they can't talk or communicate with you. And anyone, then they might even lose their temper because of it. Like it's just ongoing. You just can't take your eyes off them. It's just 24/7.
How long did you care for your dad, George?
It was in the later, it was like 24/7 care would have been the last couple of years, because we had no carers. We done it all ourselves, because he went downhill like quite rapidly. But it would have been like in the last 10, it would have been 10 years you would have been looking at, watching for him, looking out for him. And
yeah. Now that you're very aware of the symptoms of Huntington's disease, do you think that there were signs earlier than that?
Oh yes, definitely. Just with his balance and his, there would have been his balance and just even his temper as well, and he would have been depressed probably too, and the temper more so than anything.
Okay. And will you just tell everybody what area of Northern Ireland you live in?
I'm in the Southern Trust up in Armagh.
And what kind of knowledge of Huntington's disease did you experience among, say, your GP or the other health and social care professionals?
Well, our GP didn't know anything, because my dad was the first stage D sufferer up there, my dad in Hamilton, and our GP said himself that he was Googling while he was looking after my dad. He says it was all new to him, and he was learning as we were learning.
Okay, and what about other health and social care professionals? Would you have seen physios or OTs or speech and language therapists?
Yeah, you would have. The speech therapist would have come out, but they wouldn't have. My dad, he didn't like school, so he left school and he couldn't read and write. So the speech therapist, they would have been trying to keep, once he lost his speech, he couldn't write down what he was looking, and they were trying, and they couldn't get him to communicate, and even the OTs, they just didn't have the knowledge. Okay. So they didn't.
So if you're thinking about looking back over that period, and even now as you see other family members with the condition, what do you think would help Huntington's disease families like yourself, Janice?
a lot more support. Obviously, there's no HD nurse outside the Belfast Trust, and there's no support for HD families outside. And the medical backup, you can even see forms filled in and things like that. It just gives them a total meltdown, and then they would lose their temper with it as well, and more knowledge of HD in the help them.
Okay. Yeah, that's fairly common. I suppose what we hear from people is that they're often met with kind of blank expressions when they go to see a doctor, or they go to see an OT or speech and language therapist. And
yes.
Us as a charity, we often get calls from these people asking us for information and medical advice and to help them do their job. And while we can provide some training around the disease and the impact of the condition on the family, we don't provide medical training. And that's really where you see that gap, because the HD specialist nurse is intended to be a coordination of care and a source of expertise and information and support to other health and social care professionals. So you really see that lacking. So I'm going to pass over to Dr. Seamus Kearney now. Thank you, Janice.
Okay.
Seamus, you can introduce yourself and your knowledge and experience of Huntington's disease just to set the context.
So I'm a consultant neurologist in the Belfast Trust, and I'm involved in the care of a large number of patients with a variety of progressive disabling neurological conditions, including Huntington's disease. I suppose, today I want to maybe illustrate why I view Huntington's disease as a unique condition with complex needs, and it sort of reiterates some of the points we've talked about in terms of the key roles in the care of Huntington's disease, describe what current service provision is like, and maybe highlight what I think is needed for people with Huntington's disease. So, I've got a good overview of what all sort of progressive disabling neurological conditions are like. But even among all of the conditions that I see, Huntington's disease really does stand out for me. And we've heard about the variety of symptoms already, but I suppose the easiest way to think of Huntington's disease is consider some of the worst features of conditions like Parkinson's or MS that affect mobility and coordination, features of dementia and features of motor neuron disease, all rolled into one condition. So the patients that I see with Huntington's, you see them losing progressive loss of limb function, balance and mobility. They'll invariably become wheelchair dependent. Speech often becomes incomprehensible. Their swallow declines, leading to chest infections, nutritional problems, choking, discussions about tube feeding. They inevitably will develop dementia if they live long enough with it, and their life expectancy is significantly shortened. And all of this is really complicated by high rates of quite severe psychiatric illness. And we know that rates of attempted suicide in people with Huntington's disease are higher than other neurodegenerative conditions. It also stands out because of the hereditary nature of the condition, and that's already been sort of very powerfully illustrated by the videos and Janice. And it's a rare condition, so as we've already heard, other healthcare professionals will be unfamiliar with the condition, and it would be difficult to expect every healthcare professional to have expertise in Huntington's disease. So because of this here really multifaceted nature of condition, their care needs are high and complex. They'll need input from genetic services, they need input regularly from neurology, often need input from mental health services or dementia services, and as we've heard, they need a variety of other professionals, physios, OT, speech and language therapy, dietitians, counsellors, social workers, and other specific services more geared for younger people with the condition. They receive immense support from the staff of Huntington's Disease Association of Northern Ireland also. So, I suppose the way I would view it, the care required for people with Huntington's disease is truly multidisciplinary, far more than any other condition that I would see. And although all of the professionals that I've listed already are essential, I think two particular specialties warrant a more detailed discussion: the Huntington's disease care coordinator or specialist nurse, and the neuropsychiatrist. So if you think first about the Huntington's disease care coordinator, they are absolutely integral in the care for people with Huntington's disease. They can identify the changing needs and liaise with the necessary community services, coordinating their care. They're a point of contact, and they're really a point of continuity for people with Huntington's disease and their carers. They also have a massive role in education, both for the patient and their carers, but very importantly, healthcare professionals in their locality. And we've heard already that despite a 2007 recommendation that there should be 5 Huntington's disease care coordinators throughout Northern Ireland, at present really we still only have 1 covering the Belfast Trust and the Southeastern Trust. So patients in the other health trusts really don't have access to this role, and it makes managing these patients very difficult and makes caring for a loved one with Huntington's disease unacceptably difficult. In terms of neuropsychiatry, my view would be that some of the psychiatric manifestations and the behavioural manifestations of the condition are often the most difficult to deal with. However, it's one of the most treatable. It's one of the ones that actually can get better. And although many people have excellent access to psychiatry and mental health services, this isn't always the case, and that there may be a variety of reasons for that. Perhaps unfamiliarity with the condition, or perhaps a view that it's a neurological disease, not a psychiatric disease, and therefore the neurologist should be managing the mental health issues. But psychiatry and the mental health team are the service with the greatest expertise in helping these aspects of the condition. So that's where neuropsychiatry and a subspecialty called neuropsychology are really crucial in assessing these difficulties, advising on treatment, and liaising with the community mental health teams. And like the Huntington's disease care coordinators, there was a recommendation from 2007 that there should be at least 5 dedicated neuropsychiatry sessions per week for the care of Huntington's disease. For many years, we had 1 session that occurred 4 to 6 times per week, 4 to 6 times per year. So 1 session 4 to 6 times per year rather than per week. And at present, there is no neuropsychiatry service for people with Huntington's disease. So we move on to, how current services are provided. People with Huntington's disease should attend a neurologist, but we're all aware of high outpatient waiting times, both for new and review neurology appointments. And I think it's inevitable that there are people on new patient waiting lists with undiagnosed Huntington's disease. We do have nominally a Huntington's disease clinic in the Belfast City Hospital, but this only runs 4 to 6 times per year, and when it runs, other activity has to be cancelled. Patients would benefit from regular review, but the current capacity wouldn't allow that. Maybe perhaps 1, perhaps 2 appointments per year. And it's really not a true holistic multidisciplinary clinic when you compare it to other centres in the UK. It doesn't have access for all patients in terms of the Huntington's disease care coordinator. As I've said already, we don't have any involvement from neuropsychiatry, and there really isn't any on-site direct presence from the wider multidisciplinary team. So people with Huntington's disease need to access these services through their community services, often in a piecemeal fashion, perhaps with professionals, whilst very willing to help, but may have a lack of familiarity with the condition. I think it's also important to highlight that actually the majority of patients don't even get to attend the Huntington's disease clinic. The majority are out in general movement disorder clinics or even general neurology appointments, where there are shorter appointment times and no on-site access to any of the services. So, I have to say, even being involved in the service myself, my own view is that service for people with Huntington's disease in Northern Ireland is inadequate in multiple ways. There isn't any proper regional multidisciplinary service. There's inadequate capacity. There's lack of neuropsychiatry and neurology or neuropsychology input, and the current care for their complex needs isn't cohesive, and there's clear geographical inequity really in terms of the Huntington's disease care coordinators. We'll maybe hear a little bit more from this from Lauren, but this is a sort of very hopeful time for people with Huntington's disease. There's a number of very encouraging experimental emerging treatments for Huntington's disease that essentially could make a curable or an incurable progressive condition very treatable. And at present, Northern Ireland doesn't really have the access to such drug trials. And worryingly, if and when such treatments come into clinical use, there's a risk that we don't have the infrastructure to initiate people on these treatments, and there could be at a risk of delaying them. So I think taking all this into consideration, I think people with Huntington's disease really need a proper regional multidisciplinary service with adequate capacity. There needs to be access for the care coordinators throughout all of Northern Ireland. There needs to be access to neuropsychiatry. They need a care pathway so that their overall care is more cohesive and streamlined and occurring in a timely fashion with people who are familiar with the condition. They also need access to research, and we need to start looking at building a proper infrastructure for any emerging treatments and looking at ways to identify people at risk of developing the conditions. So I think my summary of the whole situation would be, you should view Huntington's disease as a complex and unique condition, and it should be viewed as exceptional. The current services are inadequate. There's geographical inequity, and within Northern Ireland, previous recommendations regarding Huntington's disease haven't been implemented. And we know that other parts of the UK, such as Scotland, London, have a really world-class model for the care of people with Huntington's disease. And there really should be no reason why Northern Ireland shouldn't replicate this. My own observation of seeing people with Huntington's disease over the years is that the people and their carers and their family are probably the most resilient people that I've ever met, but they really need additional help and support. And I would really ask for your support and assistance in development of Huntington's disease services in Northern Ireland.
Thank you, Seamus. We're going to hand over now to Dr. Lauren Byrne, who, as I've mentioned, is a research scientist based at the University College London in their Huntington's Disease Centre, and also from a Northern Ireland Huntington's disease family. So over to you, Lauren.
Wow, I don't know what else I can say after that, Seamus. You've covered it all. So I'm Lauren Byrne, and I am a research fellow at the University College London's Huntington's Disease Centre. So I bring both a personal and professional perspective, as I'm from a HD family here in Northern Ireland. My dad has HD, and many of my family members are affected. I have been tested and tested negative for the disease, but my brothers and sisters are still at risk, and it's still a very real personal aspect to my life. And it's a real privilege for me to work at the UCL Huntington's Disease Centre, as it's a world-leading HD research centre, and it provides exemplary specialist care for the HD patients in and around the London area, in particular with their multidisciplinary approach, which was highlighted by Seamus of why that's important. And working at the centre has afforded me opportunities to meet leading HD experts and professionals across the world who are working on HD, and it's exciting, as Seamus mentioned, a very exciting time for HD research, and the prospect of drugs that might actually slow the disease is very real. I felt a lot of the frustrations mentioned already in the videos and from Janice, that many HD family members feel in Northern Ireland that they're alone, that no one really understands the disease or cares, or what help can they give anyway. And that's a feeling that is current in my own family. And it wasn't until I joined the team at UCL where I actually had hope and a vision for how patients in Northern Ireland with HD could be supported. And for the first time in my life, I was meeting clinicians and professionals who not only knew what the disease was, but actually understood the complex needs, and had that time and empathy to really support those who suffer from it. And Seamus has already commented on this, but HD is historically been treated only in neurology or lodged in that specialty, but it's very complex and requires a coordinated input from other specialties, in particular psychiatry, speech and language, physiotherapy, etc. The current numbers for HD in Northern Ireland are likely much lower, as probably already mentioned. And in my family alone, I have at least 35 people at risk, not to include the 3 or 4 people who currently have the disease. And there still remains so much stigma for families, particularly in Northern Ireland, which prevents families from talking and reaching out for support. And because of their experience with professionals that don't understand, they often are less likely to engage with services if there are, and maybe don't even know what services are available to them. My biggest frustration is the lack of HD research in Northern Ireland and the lack of infrastructure that we will have to make it happen. In my professional life, I'm really excited by there's so many companies now getting involved in HD research, and in developing their own bespoke drugs, and the first therapeutic that has been specifically designed to target the root cause of HD is now at a pivotal trial, which will assess whether it is going to work or if efficacious to slow Huntington's disease. And this is really exciting for the global HD community. However, if this drug works, we are so far from being able to implement the infrastructure in Northern Ireland for our patients to have access to this drug. And that's a real sad thing to say for all of our patients in Northern Ireland, including my own family. And there are many more drugs coming and many more trials that need patients to fill them. So there is so much potential for Northern Ireland to be a part of these efforts, and the patients in this community to be driving these efforts. So I've been working with HDANI and Seamus for this specific goal in particular, to try and get research into Northern Ireland for HD patients, and having an all-party group for HD will greatly accelerate our efforts. Thank you.
Thank you, Karen. Okay, just a second, and now. Okay, I'm just going to make a few conclusion points, and then I will pass over for some questions. So just bear with me and we'll go with the technology again. Okay. So just to surmise some of the issues we've identified there that affect the Huntington's disease community, there's no accurate data on Huntington's disease numbers in Northern Ireland. There's no HD care pathway. There are very limited HD specialist services, and those tend to be centralised to Belfast. There's currently only one Huntington's disease nurse specialist, and she's only accessible to people within the Belfast or South Eastern Trust, which in and of itself is an excessive caseload. There's poor coordination of care and inappropriate placements, and limited knowledge of Huntington's disease among health and social care staff, with no opportunity to build peer expertise and networks of support. There's inadequate respite, residential and palliative care services for people with Huntington's disease. Families and professionals are dependent on HDANI as the only charity looking after Huntington's disease, but we as a charity have no long-term sustainability. There's a postcode lottery of access to specialist care, research, clinical trials, and things such as IVF to prevent the Huntington's disease gene being passed on to the next generation. And there's very serious concerns over equitable and timely access to future disease-modifying therapies in Northern Ireland. So what we're asking MLAs to consider is the establishment of an all-party group in Huntington's disease. And the purpose of the group would be to raise awareness of the issues affecting people with Huntington's disease, those at risk of inheriting the disease, their carers and family members in Northern Ireland, and to ensure that these issues are reflected in relevant policy and practice in Northern Ireland. So we are asking you today to pledge your support to this group so that it might be established without delay. Thank you. I'm going to take some questions now, and I think Colin's been waiting, so I'm just going to unmute you. Colin, you try that. Hello, Colin.
Can you hear me now, Sorcha?
Yes, Colin, go ahead. Thank you.
Okay, well, thank you. Quite profound, I have to say, and thank each and every one of you for sharing both your personal and professional stories. And I have to say, I'm a little bit shocked, and I didn't think, in terms of the lack of support, and I am not naive in relation to the overall lack of support for many conditions, but just in particular in relation to this, I find the absolute lack of any kind of specialist support across those areas. So I'll make a few comments maybe, and then a couple of questions towards the end. I am aware from the APG on cancer, or I became aware as a result of that APG, of the issue about rare cancers, as they are called. However, I have come to learn through that work that actually so-called rare cancers are responsible for the deaths of well over 50% of our cancer deaths here. So it's a strange thing to still call them rare when they're actually so prevalent here, and I'm not sure why that is, but I'm aware of it. The other thing, I was very struck by by Seamus's presentation there around the whole issue of regional inequalities, and all of the MLAs here are probably well aware of the issues around neurology with the Belfast Trust, and we do hear often about these regional services. And I have to say, it's something that I've been given increasing thought to recently around. So there's two ways of looking at it, regional services. There can be one service for the region, or it can be services appropriately placed throughout the region. And for me, it would always have to be the latter rather than the former, because we have seen increasing problems where when you locate a service in a particular, say in Belfast, as a lot of them are going to, first of all, in the neurology recall, that then placed huge pressure on the Belfast Trust because they were holding the baby in that respect of dealing with it, and it put huge pressure on the other things. In relation to the contaminated bloods scandal, people from Derry were having to travel to Belfast for the psychiatric support. And clearly, the very fact they needed the psychiatric support was a huge barrier to begin with to make your way across the Glenshane Pass. So to me, transformation and regional service has to mean that we develop a model and a system that works for our people here. And this, what I sort of started to think of recently as the Manchester model, which we hear about, or indeed the London look. You can't just take numbers and transpose them and say, because that works for this amount of people, this is how we'll develop our service. And that's increasingly important across a range of stroke and a range of breast cancer and all these services. So I think that's something we do need. I believe in transformation, but I believe it has to be providing better for everyone, including people that are affected by this. It's also interesting to me in terms of the multidisciplinary aspect of this, which I wasn't aware of, and that's very useful to know. And thank you for inviting me along for that alone. But just the range of multidisciplinary disciplines that are involved with this condition are huge, and are, that's quite instructive. And we would, I think, most of us do support the increase in building up the multidisciplinary teams in primary care, and maybe that has some potential for the future, but it certainly doesn't do much at the minute. Finally, for me, the inequalities, absolutely massive, both geographic and psychiatric and all of that there, and those inequalities we have to really tackle. There's no question about it. And unless everything we're doing is addressed towards tackling the inequalities, it just gets buried in all of this other work that's going on. So that's something. The final 2 points to make are the lack of data worries me, but doesn't surprise me in a sense. Now, we heard as lately ago, I think as yesterday, I'm not sure which of the meetings I was at yesterday, whether it's Health Committee or some of the other things, that we have world leading, or at least island leading, record keeping in terms of electronic data with the NICER system, and we're also investing heavily in Encompass, but we're continually hearing that there's a lack of data within the system, and I have to ask myself why that is. So it would seem to me the most fundamental thing to measure how many people you have with a condition so you can plan the services, and what gets measured gets done. And the converse of that's true. So what's not getting measured doesn't get done, and that's what's happening here. And I'm aware from a series of letters I wrote to the trust some time ago around carers, just the carers aspect, and Janice has referred to that hugely important aspect. But the trusts don't even have joined up lists of how many carers. They haven't nearly enough carers on their books. There's wide disparity between the levels that they have across the trusts. So these issues, so if we have a NICER system in place and an electronic record, how come we're not using it to capture these various metrics which we would need to be measuring? The other thing I just did want to say was that in relation to that issue that Janice talked about the care and that, at Health Committee yesterday, we pressed the Chief Scientific Advisor around some of the restrictions in terms of people's bubbling and support. And we made the point to him, and it struck me on reflection after the meeting very forcefully around that whole issue of chatting and emotional support and hope. And actually, I think that's the conclusion of all of that issue of hope. So it's not good enough to say, oh, the carers are still going in and the person's getting the physical. There's more to life than care. And we cannot park people up as being recipients of care and not consider the whole social isolation, the family support, all of that. Now, that was in relation to issues that we have identified within the committee, potential issues with the social bubbles. It's a minor enough issue in that sense, but a huge impact, as you know, and I appreciate you for bringing that out. And all of us will be better armed tomorrow than we are today as a result of having this broad discussion. The final thing I want to ask is, I'll ask the question last. The other thing that I am going to do, and I have absolutely no issue with an APG. I am aware there's a huge amount of APGs, and I certainly wouldn't do it the service at the present time. I'd be quite happy to be involved and quite interested to be involved, but I wouldn't have the capacity in relation to this particular one. I'm also setting up a carers one at the minute, because that's a particular interest that I have. But I am going to write to each of the trusts and to the minister around that issue of the specialist nurse, because that's just basic stuff, like, and that's not a massive budget. That's just that's priority that's behind that there, and it's absolutely unacceptable to me that the people of any rural area, and I note that ours is particularly affected by that. So I will be doing that as a minimum, and I'll be considering what else I can do as well. And then finally, I did note within your slide, and I suppose as a constituency rep, you always focus in, but I did notice 2 clusters in the Enniskillen and the Irvinstown area. And I suppose my question is that linked to the fact that this is genetic? So that's likely a sort of a family group rather than environmental. And I do notice clustering more broadly, that clustering seems to be, so there's a positive and a horrible way of positive in that they're identified, and these cases are so readily identifiable. So there's almost an excuse for not doing something about cases that you don't know. It's not a great excuse, but you see when you know they are and you can see where they are and you can plan in the way that you've set out there. I just think it's an absolute shame and disgrace that those nurses, at the very minimum, that's not a massive expense in the overall budget, and it would provide hopefully the gateway to all of the other services that would be required. So thanks very much. It's a horrendous situation for people to be in, with that thing of the 50% hanging over you, and also the progressive nature of it. And we're all aware that our services are well geared up for end of life, and essentially you all are palliative, even though you're not end of life, but you're not. Palliative and end of life are kind of wrapped up in the psyche here, that the system does in some ways and in other ways doesn't. We debated in the Assembly the other day the idea of having to remove the 6-month limit for terminal illness to access benefits and that. So it's a very difficult, and I have to say the grace and with which you all have carried it and has been reflected, and the pain in that, I deeply appreciate you sharing that, and I will do those things, are things that I will certainly commit to do. Okay.
Thank you very much. Just to pick up on a couple of things that you've said. So Seamus mentioned that in 2007, there was a report commissioned, and that was commissioned by the Health and Social Care Board. It was a report that was led by Dr. Jenny Jingles at the time, and it involved both professionals working across the spectrum in genetics and neurology, mental health, as well as patient and carers. And it concluded that there should be a HD specialist nurse in each trust area, and that there should be a regional coordination of care. So it's 2007, so you're talking 13 years ago, and slightly more now. And over the past few years, since the charity has become more established, we've been lobbying heavily on this issue. And at one point there was a second post created, but that too was limited to the Belfast and southeastern area. So slight progress was made. Ultimately the person left the post. They didn't feel it was a good fit. And that post hasn't been filled since. In the past couple of years, the department had established a Huntington's disease working group to look at service development, and we were integral to that group, and we got some degree of commitment that there would at least be 3 Huntington's disease nurses to cover Northern Ireland. And then it got down to the nitty-gritty of the Public Health Agency and the Health and Social Care Board commissioners saying, well, where should these people be based? So we provided all the data and evidence that we had to demonstrate, for example, the complete absence in the Western Trust, the Northern area. And we were told then it would be a case of approaching the trusts and asking them to commit to appointment. I went off personally, I went off on maternity leave for a year. And when I came back, I followed up immediately on this issue and was told, oh yeah, it's still with the trust. We're still waiting for an answer back. Over the past 6 months, I've sent numerous emails and I don't even get a reply. And that's the reality, that they've just completely dropped off the radar.
No, do you know what, Sarga? I was going to say, actually, I should have said the first time, it would help me very much if you'd send us on the presentation that you give for information. Yeah. And while the presentation was running, like I was thinking to myself, I would be prepared to sit down with the trust or the department if they were sitting saying, listen, and I'm not gainsaying this, but if they were saying, look, there's not enough cases to justify, I could almost tolerate that if they were saying, but what we will do is we'll ensure that there's 2.5 days a week in the Western Trust plus 2.5 in the South, or whatever they could make a business type case on, to use that horrible language. But the thing about doing nothing is just absolutely not acceptable. The other thing I will do, and I'm sure Paula will agree with me on this, we will report this conversation back into the Health Committee, and we'll keep it in our minds. We're absolutely inundated at the minute with issues, but we will keep it in our minds, because the rebuilding of services and the notion that we absolutely must rebuild back better does provide an opportunity for saying, right, if there are new rebuilding decisions being made, let's plug the gaps that we know are in the system.
Yeah.
And if you want to send me some of the emails back and forward, just in terms of for information for myself as well, because I don't think that's acceptable. That level of neglect of an identified need that's not being attempted to be met, it seems to just be floating out there. No, that's not good enough.
And just to answer your question, Colin, that you mentioned in relation to the clusters, so the mapping, as I illustrated, only can show the people for which we have postcode for. But when you're saying clusters, it is generally extended family members. So because of the hereditary nature of the disease, rather than any environmental issues. So you'll see clusters all across Northern Ireland, and you'll also see clusters along, for example, the North Antrim coast, and similarly on the Scottish coast, where families have immigrated and patterns then have created across the UK as a result. So I'm going to hand over now and see maybe if, say, Paula, you have a code? Yep, okay.
Sorry, I actually have to go in 1 minute, but I think I'm just going to pick up on the point Colin made there. In the rebuild plan, they did say they were going to do a review of all care pathways. So there's an opportunity there to follow that up. The APG, the last thing I did before joining the call was to email the Secretariat for the APG and Cancer to say that there's a clash with autism and dual diagnosis and addiction, and our health committee's stakeholder briefing on our committee inquiry. I'm not sure whether there's any room in terms of getting the people, because probably about 60% of the APGs are health related, and it's the same people going to them. I do know that Roy Beggs is looking at an APG on MS. I know that Parkinson's want an APG. I know that ME want an APG, and I'm just wondering, is there any way that you can maybe look at it as an APG on neurology? I appreciate that would dilute it somewhat, but what we do in cancer is we would take a different subject each meeting, and I suppose it's almost like that better than nothing. But I do want to follow on to say I've been fighting with the Health and Social Care Board for years on their regional multidisciplinary service for ME. I think it goes back to 2012. Seamus, what you said there, I could have, now I know ME is not the same as Huntington's disease, but in terms of the frustrations and the promises and the commissioning and all the rest of it. So I'm wondering if something we could do as a health committee. I'm sorry, they're also very similar thing as well for facial palsy, regional multidisciplinary service. I'm just wondering, is that something as a health committee we can actually bring the Health and Social Care Board to us to say what is happening with these regional care pathways? I suppose that's something that we could do to put them not on the spot, but ask them to come along and give us information, shine a spotlight on it. But the final thing I'll ask is around just picking up on the facial palsy. And Seamus, I think you mentioned a few good service models in GB. I know that there's a part of England, can't even remember the name of it, but they were going to bring an in-service clinic into Northern Ireland just while things got set up here. Is that something that is possible or something that's been explored?
So in terms of bringing in service from elsewhere, in terms of Huntington's, is that what you mean? Yeah. I mean, I suppose we would look at any model. There's clearly expertise, particularly regarding the research. We're decades away from, developing our own research infrastructure. So if that was to ever develop, it clearly would need to be through links from one of the more established centres. So yeah, I mean, all of these models and approaches should be considered. But I think particularly for research, some of the, inward help from some of the other centres would be very reasonable. But I think in terms of the day-to-day care, we need to probably just build our own services and deliver them in whatever model we feel is best fit for Northern Ireland.
Yeah, certainly. I think we've got some good links, Paula, with other research centres around the UK. And even yesterday, we delivered training to about 180 health and social care professionals with a partnership with the Birmingham and Solihull Mental Health Foundation Trust, who have a HD regional centre there. But one of I suppose the key aspects, as Seamus has mentioned, is the need to really build our services here. Because if we bring in help from outside, that's grand, but it's only going to push things down the road further, and it could be seen as a bit of an out, I think, in some respects. Now, we do have a commitment from the lead clinician in Birmingham to bring an Enroll HD, which is a global research infrastructure, to bring a visiting clinic to Northern Ireland. And we had planned to do that over the summer before COVID hit. But again, that is only really to allow us to get some links into to Enroll and to allow some people from Northern Ireland to engage in research, but would mean that then it would be an opportunity, as Lauren and Seamus have been working, if local, say, genetics nurses or anybody here had an interest in developing research, they could learn through this visit. But really, it's not a case of buying in services, it's a case of building up our own expertise here.
Yeah, well, that's what I meant. It was more just to sort of hit the ground running then for it. But I'm sorry, Fridays are just blocked out, so I'm going to have to go. But I would appreciate the slides, as Colin has said, and we can chat offline around this and maybe coordinate. Colin could do some things, I can do others. Pam certainly, and Sinead or Colin McGrath, who's be the health spokesperson for SLP. But happy to divvy that up and then look at the APG and maybe that sort of wider neurology family or something. I just think that otherwise you would find you would get one or two people attending and you would feel quite despondent and it wouldn't get the attention that it requires.
Okay, I will certainly come back to you on that, Paula. Thank you. Sinead, do you want to make any comments before we...
Yes, thank you, Sarah. And firstly, apologies because I was in and out there. I got my intention was to be here and I got a bit distracted at the start, but I was able to follow the slides and unfortunately not so easily the video. But yes, I take a few points I'll just run through. I don't accept about the data not being there because it is there. The data is there, it's not correlated and it's not shared. But there's no doubt in my mind that there is enough data held within the department that could be a key to understanding where services should be and how they're directed. And this whole conversation takes me back a few years where I walked this very similar path along with the MS Society, who started with just that conversation. They were talking about there was a lack of specialist nurses within the MS Society, and their battle was to try and get one across each trust area and looking at what is a specialist MS nurse and what tools or what scope is there to training people up. And they've certainly been quite successful in that regard. But then when you're talking about such a small number of people, and like Seamus said, it's about that whole infrastructure and services and being able to develop it. What can happen is if one person leaves the post, there's not an automatic easy fill to it. So it is about all that support that comes with them and everything that builds around it. In terms of, there were so many critical good points raised here. And in terms of then looking at where is the desk that you ultimately want this to be in front of to find the solutions. And I appreciate that there are challenges, obviously, in the Minister for Health's desk at the moment. It's hard to get his ear on anything, which is understandable, given the circumstances. And I can understand why then you would look to the APG model. And I'll just be honest about the APG model. During the downtime of the Assembly, APGs became a really worthwhile vehicle because you had MLAs who weren't constrained to committee time or Assembly chamber time. And APGs were a real good vehicle for us to be able to communicate with groups like yourselves. And we were able to, even though it was only through the department secretariat and permanent secretaries, we were able to carry on a level of work through APGs. But the truth be told, when the Assembly then did restore and our time was started to slot in, as you would expect. It would be, you know, with a Monday and Tuesday taken up with plenary, and then committee slots were filled up for Thursdays. Now, APGs then started to find it really difficult, and I had started up my own APG on loneliness, and you'll find that a lot of members have, and it's so difficult to even find a day or an appointment day where I can get more than 2 MLAs in at the same time. So it's not the easy answer it might appear to be. I can see why you think it would. And also I do take the point, it's been suggested a few times that maybe organisations like yourselves and small, you know, it is based on volunteers and people who are giving of their time, trying to then team up with other APGs, and the danger there is you get lost. You know, your issue can become lost. That's specific, but I do wonder, is it worthwhile trying to distill this work further and say what does belong specifically to HD, and what are the shared pieces of work in terms of building infrastructure and data, and that the department need to get better at anyway, and that you would become a benefactor of. That might be work you could feed into a similar type APG, but it doesn't take you off. Then it allows you then to really focus on what is specific to you. For example, the HD nurses against the trust. That's very specific to you. You know, where is that skill set, and how, you know, that's a very clear ask. So I'm just trying to distill a lot that came at me there, and there is plenty there. And what I will commit to doing, and I know Colin, I think the others had to leave, but it would definitely be worthwhile is to not lose a bit of this momentum now, and to come at me with a really clear ask and say, Sinead, could you ask the minister to do something on X, Y, and Z? And I'll do that. You know, I can go directly to the minister and put that into the department and get the information flowing back to you. So we have a really clear understanding of, and I know one of the bits of research I did for the MS Society at the time, when they were doing this exact piece of work, we were in one of the clinics, and I'm sure you probably will recognise this when I say it. We went to one of the clinics in the Royal Ward, don't mind saying, but the doctors were there, the specialist nurse was there, but everybody in that waiting room came from a postcode area where they had all travelled for an hour and a half to be there.
Yeah. I mean, at this stage, families are so desperate they wouldn't mind travelling, but really the reality is we need to make services accessible.
34 postcode and travel to Belfast.
I think we're losing you there, Sinead. Your bandwidth is showing as being low. I'm gonna just
exactly. That's this service is needed, but it's needed at the data to share. So I'm happy.
Okay. Thank you, Sinead. Sorry, you've cut off there. I'm going to pass over to Don. No, go on ahead. You're representing Pam this morning.
Sorry there, it's just I have a constituent waiting to see me here, so I have to go for another meeting. But look, I would just like to say thank you very much for letting me join this morning. I will obviously write up the notes and pass it on to Pam. But if you could also, you know, include us in any correspondence and the slide from today, Pam would greatly appreciate it.
Absolutely. Thanks very much.
Right.
I think we'll leave it there, and we'll be following up with everybody with a copy of the video and the slides and all of the information. So thank you all very much for your time.
And thank you very much indeed for your time.
Thank you. Bye-bye.
Okay, bye.